Right. Hi, and welcome to today's webinar. Before we introduce a speaker, I want to make a few brief announcements. We know many of you are listening in from far away and can't attend local events or programs. That is the main reason we provide this free webinar series. We host multiple webinars per month, so please visit our website to view the current schedule. The 2007 schedule will be added this month, so if you are not on our email list, I encourage you to visit our website and click on the Join Our Email List link that appears on the homepage. To get instant news and events from the Johnson Center, follow us on Facebook and Twitter, as we often announce grant and scholarship opportunities, research opportunities, and last-minute events and presentations there. You can find links for these on our website at www.johnson-center.org. Be sure to follow our colleagues at the Autism Research Institute, as they host their own webinar initiative and they share some great resources on their website and social media pages. Before we begin the presentation, please note that questions may be typed into your control panel throughout the presentation, and time permitting, they will be addressed during the presentation. Also, for those who have requested copies of the presentation, we do not send out the presentation slides. However, we do post recordings of all our free webinars on the Johnson Center YouTube channel. Please search for us on YouTube and subscribe to get full access to all our recorded webinars. Now please welcome our presenter, Amanda Tami. Amanda holds a master's degree in counseling psychology and has completed a recertification program in applied behavior analysis. In addition to being a board-certified behavior analyst, Amanda is a licensed professional counselor. She has experience working with both children and adults on the autism spectrum and other pervasive developmental disorders as both an ABA therapist and a counselor. Since 2013, Amanda has shared her experience and knowledge within the Johnson Center Behavioral Services Program, providing her the opportunity to pursue her passion in working with children with special needs. And here's Amanda.
Thank you, and thank you everyone for being here today. The topic of anxiety and autism is a topic that I'm very passionate about, and I'm so pleased that so many in our field are coming around to the idea that anxiety in autism is a real problem, and that anxiety and autism can coexist, that our population can suffer from both of these things. So today's webinar is on a very broad topic, and this presentation will give you an overview of anxiety and autism and some treatment information, but there's a lot that we won't have time to cover in this hour or go into depth about. If it is of interest to you as my audience, then we can go into more details about any of these topics presented today in future webinars. So as we go over things, as we cover this information today, please do send comments about things that you would like to see covered in another webinar, things that you want more in-depth information about. Of note is nutrition. The Johnson Center provides nutritional services, and in this presentation we won't have time to touch any dietary interventions for anxiety, of which there are many. So we will in the future do a separate webinar just on that topic of using nutritional and dietary interventions to treat anxiety. But please do send us any comments, and we can do more webinars on the same topic or on more in-depth information on anxiety in the future. Excuse me. In discussions of autism, we often hear about delayed development of various skills. These delays are responsible for underperformance in certain areas, but also for some challenging behaviors or doing too much of some behavior. So, for example, a child whose communication skills are delayed, of course, leads to underperformance in their ability to communicate their needs or to communicate in general. But this child who has this delay might also become aggressive when he's not able to communicate his needs. This communication delay is responsible for both this deficit in being able to communicate and this excess of aggressive behavior. That's just one example. There are lots of ways that communication deficit could manifest in some other, too much of some other behavior. But this can be a bit more complicated than that. Sometimes the skills do exist in the person's behavior repertoire, but some barrier prevents that person from using those skills. So, as an example, a child might have communication skills, but something is preventing them from using those skills. Often this barrier is anxiety. For example, a student is doing really poorly in his reading class and is not understanding the lessons or the homework assignments. He knows that he's struggling with these and he has the ability to ask for help, but anxiety prevents him from doing so. He might have a delay in that reading ability or verbal processing that's making the class more difficult, but a performance deficit, the ability to use the skills that he has, is preventing him from getting help. The anxiety is preventing him from asking for the assistance he needs from the teacher or someone else to improve, to get his reading level up to where it should be. Excuse me. Some signs that it might be a performance deficit rather than a skills deficit. A student uses these skills or behaviors in other settings and has shown generalization. So this student is able to ask for help when he's at home or when he's with other people, but doesn't do it at school. He's able to ask for help, but he's not doing it in this setting. The student spontaneously uses the skill in other situations. He doesn't need to be prompted to ask for help when he's in other settings. In the next hour, we're going to talk about how anxiety acts as a barrier to performance of these skills in the repertoire, and specifically how this relates to autism and the different routines to decreasing this barrier. So we'll cover what anxiety is. We'll talk about the differential diagnosis of anxiety, which can be quite complicated, and we'll talk about some strategies for treating individuals with treating anxiety in individuals with autism. Everyone has experienced anxiety. Most of us would describe anxiety as that feeling you get when you're about to give a presentation or make a big decision or make a hard phone call. Maybe it's around something, a specific fear like needles or heights. We often think of anxiety as the physiological feeling of a racing heart, that feeling in the pit of your stomach. Maybe your mind races, sweaty palms. These are all signals that you're anxious. But anxiety is actually much more than this. It is anticipation of or reaction to some threat. And it is a normal and necessary physiological reaction. Our fight or flight response is the basis of our anxiety, and it has saved all living things for millions of years. Without it, humans and most living organisms wouldn't survive. Anxiety has evolved over time, so humans used to face life-threatening dangers in their everyday lives. Everyday humans had to protect themselves from wild animals, for example. And while some humans still do face really true life threats in their everyday lives, think about war-torn Syria, where the threat of being killed is real every single day. Most humans don't live in those kinds of environments. However, anxiety is still present. Now think of the so-called threats that bring about anxiety today. They're not life-threatening. Giving a speech, being in a crowd, usually seeing or having to have some sort of needle injection. They are usually not life-threatening, but we still have this anxious reaction to them. And it's still that exact same physiological reaction that humans used years ago when they were being chased by a tiger. Unfortunately, too much anxiety in this day and age is not protective as it used to be. It can be debilitating. Anxiety is normal and it's needed, but too much of it is a problem. So if someone is too anxious to do their daily living or work tasks, the consequences can be a bigger problem than the threat is. We don't have time to go into details about it in this presentation, but when humans live in a heightened or a chronic anxious state, this creates really big problems for the nervous system and the physical body. And too much anxiety is pathological, not only for our mental and emotional health, but also for our physical health. Now, I want to go into a very simplistic explanation of how the brain works. We can't get too deep into it in this webinar, but essentially the brain works differently when emotions are high than when emotions are neutral. The brain evolved from reptiles to mammals, and the evolving brain developed on top of the earlier brain. So the mammal brain was built over or above the reptile brain. The reptile brain is still there, but the mammal brain developed on top of it. So the reptile brain is the lower part of our brain, the part closest to the spine, and the mammal part is the part that is up by our forehead. Now the reptile's brain's focus was survival, protection, and getting its needs met. So the reptile brain information comes through the spine and goes directly to the amygdala, which is the part of the brain that's responsible for the fight or flight response. The human brain is capable of much more complex cognitive tasks of reasoning and logic and planning and time sequencing, organizing, things like that. And this all happens in the frontal lobes, which is the part of the brain that humans have, and humans can do these things while other animals can't. When we're anxious or in any really heightened emotional state, good or bad, that could include when you're really, really excited or really happy, at any really high emotional state, the frontal lobes turn off and the reptile brain takes over. So when we're in that heightened emotional state or a really anxious state, the brain goes back to survival mode. We act on our emotions and without thinking. Because the information is going straight to the amygdala and not through the frontal lobes, we're not able to think about what we're doing or how big of a threat it is or how we're going to react to it. We just go straight to emotions, fear, I need to protect myself, and react accordingly. And that is the anxious response. So let's talk about diagnosing anxiety. The field, like I said previously, is increasingly recognizing the link between autism and anxiety. Not only are we learning that people with autism often do experience anxiety, but that is maybe even more common than in the average population. It's unknown whether this connection between autism and anxiety is a physical or neurological link, but excuse me. But autism behavioral symptoms may be related to anxiety. Think about the compulsions or stemming, challenging behavior, repetitive behaviors, including repetitive verbal behaviors like asking the same questions over and over, or always looking for reassurance, scripting, eloping. All of these things can be related to anxiety. They aren't necessarily related to anxiety. So, for example, repetitive behavior, like talking about a perseverative interest, can just be that I find this topic really interesting and this is what I want to talk about. It can also be anxiety, that when I'm anxious, I go to this topic and I ask the same questions about it because I'm looking for constant reassurance. I want to know that this answer is still the same now as it was 5 minutes ago. It can be either one of those things. So it takes some familiarity with autism and with the individual child who you're working with, or your individual child of your own, to distinguish between whether this is simply a symptom of autism or whether this is a symptom of anxiety. People with autism experience a different world than the neurotypical person does. So it makes sense that anxiety can be heightened in that population. Sensory input can be higher or lower. Communication can be a lot more difficult, harder to understand. And it can be really hard for some to get their needs met. Changing patterns is confusing. It's harder to predict what comes next. And how are you going to know what to do if things change? If I don't know what's coming next. I don't know how to respond to this. And the world isn't necessarily black and white. There's not always a correct response. And all of these things can be really difficult. So the very nature of autism in the world that we live in today makes anxiety likely. And anxiety makes sense. And the baseline level of anxiety for someone with autism might be even higher than for the average person. Let's think about a school, a classroom, as an example. The traditional school environment is far from ideal for a lot of students with autism. The classroom environment is inherently social. In addition to socialization with classmates that is expected, the structure of the classroom is in and of itself social. The teacher is speaking verbally. It's a room with a lot of other people. All of this information, everything, all of the ways that this person is getting information requires some social interaction, requires some social response. It also requires auditory processing. When lessons are given via lecture with a teacher at the front of the classroom speaking, and that's how most classrooms today still are, it requires auditory processing, fast processing time, and again, things that someone with autism might struggle with. Reading is also fundamental to other learning. The ability to read is kind of a building block for everything else. If you're not able to read at a certain level, then you can't read your social studies textbook or your social studies test. So everything kind of builds on being able to read. And if the student is a poor reader, then they may have lower grades, and they may perceive themselves as having lower intelligence. Their perception of themselves it can be affected by their performance in the classroom, which can also lead to anxiety, not just in someone with autism, but for everyone. That's how we learn to see ourselves, is how we succeed or fail in whatever situations we see as important to us. And when we see ourselves as failing or not doing well, it can really lower our self-esteem, our self-image, how we see ourselves. Now, there are many seemingly harmless and safe situations in everyday living that to someone with autism are frightening and can lead to panic. Unstructured time, sensory issues, social situations, transitions, unexpected changes. These are just a few of examples of these kinds of stressors that to the average person seem like no big deal, but to someone with autism are really, really stressful, really frightening, much more of a threat than they are to other people. Also common in people with autism is the fear of failure or the fear of making a mistake. Failing can not only be a social faux pas, but it can also be damaging to their identity. So, like I said before, with the reading example, if someone perceives themselves as being a bad reader, if they see themselves getting low grades and this area of their lives is important to them, then that's going to affect their self-image and how they see themselves. If someone sees him or herself as a math whiz, but getting up in the front of the class to answer a math problem on the board, having to do that could potentially undermine their identity as a math whiz. What if I get up there and I get the answer wrong? Then not only do other people not see me that way, but am I really good at math if I get this one problem wrong? Remember, for a lot of people with autism, the world isn't black and white. So if I don't get every question right, then how can I be good at this? Again, just an example, but that's kind of the idea. Now, according to Tony Atwood, who is an expert in Asperger's research, baseline levels of anxiety in people with autism are often higher than that of the average population. So let's say a typical person's baseline level of anxiety is around a 3. And the person with a level of anxiety, or a person with autism's level of anxiety at baseline is about a 7. For that baseline level of 3, an anxiety-inducing stimulus, let's take really bad traffic as an example. So you're stuck in traffic and you're going to be late for an appointment. When this typical person's in that situation, their level of anxiety goes from a baseline of 3 to up to about 6 or 7. That person with anxiety who has a baseline level of 7 in that same situation goes all the way up to an anxiety level of 10. So thinking about the scale in this way, it's no surprise that people with autism might have really big reactions to what seem like the rest of us as not so big problems. If you're living with that much everyday, with that much anxiety in just everyday situations, it doesn't take much to go into a panic. Now, when you're looking at anxiety in someone with autism, there's a lot that we need to rule out. Anxiety might look like autism, but is not. So autism can also look like anxiety, but it is not necessarily anxiety. It could be autism. So there are a few DSM diagnoses that have aspects that are similar to the way autism looks. For example, selective mutism, where someone is unable to speak in certain situations, could potentially look like autism, but it's not autism. It is selective mutism. Social anxiety, OCD, even separation anxiety are some other examples. Pandas is another example. So, for example, someone who turns the lights on and off, that might look like autism. That one specific symptom, at least, might look like autism, but it's actually would be better diagnosed as OCD for some patients. A child who doesn't say hi to a peer could be social anxiety, or it could be social avoidance associated with autism. So it's really important that we consider all of the factors in giving a diagnosis any one particular factor can't really tell us what the diagnosis should be. So it's very important that we get a thorough diagnosis, a thorough evaluation for a proper diagnosis. It's also easy to dismiss or overlook anxiety when someone who does have autism, and just say that those behaviors are part of autism. So while not saying hi to a peer could be social anxiety, it could be part of an autism symptom. It could also be social anxiety. So when we diagnostically overshadow, we just lump everything together and assume that all symptoms are just because of autism, and that's not necessarily the case. On the other hand, manifestations of anxiety in people with autism can look very different from the way anxiety is expressed in neurotypical people. And as a result, it's often misunderstood and can be a lot more difficult to diagnose anxiety in someone with ASD. These symptoms are often overlooked because of the communication deficits, the idiosyncratic behavior. It just can look very different than the typical expression of anxiety. The anxiety that we're used to seeing can look really different. Things that you may want to look for that could be indications of anxiety in someone with autism are any obvious triggers. So recent events, recent or past trauma, phobias or fears, transitions, sensory input. Also, if the child is verbalizing any worries or any fears, that's an easy way to identify an anxiety. Any changes physically in appetite or in sleep, avoidance of any specific situations or any specific objects, anything that looks like a phobia, or just not wanting to go in that area, having a big reaction if they are near something, and consistently. If it's one time or it happened one time, a one-time avoidance, one-time big reaction, then it's not usually a big red flag. But if it's consistent and every time this stimulus is presented, this reaction happens, then that can be an indication of something more serious, a possible anxiety disorder. Signs of OCD, compulsions, rituals, those kinds of behaviors they can be just related to autism. They can also be anxiety related. And signs of panic, those physical symptoms that we talked about, increased heart rate, feeling of overwhelm, difficulty breathing, sweating. And in children, especially those with ASD, anxiety may show in more typical ways, like behavior changes, more challenging behavior, really big emotional reactions, can be perseveration or repetitive behaviors. And although rates of anxiety are, by research, are indicated as higher among those with so-called high-functioning autism, this may only be due to their verbal abilities and their ability to respond to standard measures of anxiety. Those who are less verbal and who need more support are likely expressing anxiety, but in different ways. They're not able to say, I'm scared. They're not able to complete the anxiety assessment tests. They are probably still experiencing anxiety, but we don't have a way to measure that or to prove that. But they do have the behavior changes and the behavior indicators that anxiety is happening. On top of all that, it's also important to rule out any physical or medical conditions with new onset of anxiety. These can include endocrine system dysfunctions, intoxication or withdrawal from medication or alcohol, hypoxia, heart arrhythmias, metabolic abnormalities, and neurologic disorders. In addition, in a 2013 study in the Journal of Abnormal Clinical Psychology, sensory processing problems and GI problems were shown to be interrelated and possibly have a common underlying mechanism with anxiety. In this study, they looked at children with chronic GI problems and found that these children had significantly higher rates of both anxiety and sensory over-responsivity than the control group of children without chronic GI problems. So lots of factors to consider here, and lots of ways that anxiety can manifest, not only in those behavioral or emotional symptoms, but also physically. If new symptoms of anxiety are coming up, consult with your family physician and make sure that no medical interventions are necessary, not only for getting the diagnosis of anxiety, but also for controlling any symptoms, especially physical ones. So now we know what anxiety is and some considerations when diagnosing it. Let's talk about how to treat it. When considering treating anxiety, not only for someone with autism, but in general, we need to look big picture. What are the situations that cause anxiety, and in what areas do we need to make changes to see improvement? So we need to also manage any coexisting conditions. Anxiety might not be the only issue. There might be some skills deficit that is needed or there might be a skills deficit that needs to be addressed in order for the child or the student to be able to feel confident and not so anxious in the situation. So learning differences, mood disorders, language disorders, social delays, these are all areas where, especially with a child with autism, we might also see challenges in these areas. And if we can also target those, if we can also address those challenges, we can make it more likely that giving some coping skills or giving that treating the anxiety can be more effective, because they also no longer have or have less of this underlying problem. If we can address these, we increase the likelihood of success. We can also help to reduce the need for self-medicating, for challenging behaviors, the need to express anxiety in less adaptive ways. So there are lots of components to treating anxiety. I've already said that it can be necessary to get some medical intervention as well. But behaviorally and emotionally, the model of intervention is multi-component. We can use strategies of prevention using positive behavior support strategies where we use things like visual schedules or visual cues, prompting to make that anxious behavior less needed, that anxious response less needed. When we know what to expect, when we know what is what's going to happen, then anxiety decreases. I know what to do. I know how to respond. I can handle this. then the need for that anxious response is decreased. Systematic desensitization is really important in treating anxiety. In systematic desensitization, we are exposing the person to that anxiety-inducing stimulus a little bit at a time. So, and then gradually increasing that little bit. So, I like the example of a boy who would get very anxious about building towers with blocks, because when they fell over, when the tower fell, it was very upsetting. That was a huge problem for him. He did not want those blocks to fall over. He wanted to build the tower higher, but he didn't want the tower to fall over. So he avoided blocks because he was so afraid of the tower falling over. So we used systematic desensitization, which is kind of like the behavioral principle of shaping, if you're familiar with that. And we would just build the tower a little bit at a time, just maybe 2 blocks, and look at his reaction to that. And remind him at each step, okay, we're going to go a little higher, and then knock the tower over after only just a few blocks. And when it was just a few blocks, it wasn't so bad. Look at his reaction. Can he handle 4 blocks falling over? Yes, he could. That wasn't so bad. That felt good to him, or that it didn't feel good to him, but that was not such a big problem for him. And we would talk about that. Oh, look, the blocks fell over. That's okay. We can build it again. And gradually, adding 1 block at a time, knock it over. How is he responding? If he had started to have a big reaction, maybe we'd go back down to 4 blocks. Maybe we would stay at 5 blocks and continue to build it and knock it over until he was able to, until that wasn't so scary for him, until that wasn't such a big deal. When we avoid, we never learn that this thing that we're afraid of is not a problem. We never learn that it's not scary. If we expose that child to that thing that's scary, they learn that it's not so bad, that they can handle it, that it's going to be okay. But when we are exposing them to that, we need to help them to cope with it, to find a way to change it if it's something that can be within their control. We need to help them help it not feel so scary. If we're just exposing them to whatever is so scary over and over, it can even be traumatic because they don't know how to cope with it. It's so big and it's so scary that it really feels like a threat, and it can be traumatic. So we need to do it gradually, and we need to do it in conjunction with teaching them another way to respond. So to teach them another way to respond, we can teach them a replacement behavior. And that can be something that will solve their problem to decrease their anxiety, or it can be a coping behavior, or it can be a brave behavior. A brave behavior is a behavior that is an alternative to the anxious behavior that they're doing, and we reinforce that brave behavior. We do that by pairing the anxiety-inducing stimulus with a reinforcer. So let's think about someone who is terrified of loud sounds. If we go into a situation where we know there's going to be a loud sound, maybe we give them their favorite toy before that loud sound happens. And that way we're pairing that sound with this reinforcer, this thing that is really good, this really bad thing goes with this really good thing. It can help to make this really bad thing not so bad. Gradually, we need to fade that. So maybe they get the toy for less time, maybe they get it only right before the sound, and eventually we stop pairing and move to reinforcement. If they can stay in the room when that loud sound happens without their toy, then they get their toy. If they can move a little bit, now they need to move a little bit closer to the sound to get the toy. So it's the same shaping procedure that we would use in any behavioral intervention, but the behaviors that we're looking at are anxious behaviors, replacing anxious behaviors with brave behaviors. We can also use things like prompts or coping skills as replacement behaviors. This is a prompt that someone might use when they start to get upset. When I feel myself getting anxious, I do these steps. So having a visual like this can help them do it on their own so that you don't necessarily have to be there every time to prompt them, because it will require prompting, which we're going to talk about a little bit later. So this is one example of a way to prompt. Just a verbal prompt is also effective. Relaxation training is important in teaching coping skills. The student needs to be able to learn to manage their anxiety on their own, and relaxation training is great. For little kids, you can teach them to notice the difference in their body between being anxious and being relaxed. I like the example of a foil ball and a wet noodle. You tell them to make their body a wet noodle and loosen everything up like they're a wet noodle, and then make themselves a really, really tight foil ball. And they tighten all their muscles and curl up into a little ball, and then go back to wet noodle. Just go back and forth between the two. And it just is a way for them to feel the difference in their body between being relaxed and being anxious. Progressive muscle relaxation is great. It can also be a great tool to help a child or an adult fall asleep at night. With progressive muscle relaxation, you start at your toes and tighten and relax one set of muscles at a time. So you do your muscles, and then you do your feet, and then you do your calves, and you just gradually go up through your body until you're all the way at your forehead. And each time you contract a set of muscles, you inhale, and you exhale as you release the muscles. And this is just a way to physically relax, and it's really great for helping with sleep, as well as just to calm the body. The physical signals of anxiety are often the first to come online when we experience anxiety. So if we can control those, if we can manage those a little bit, then it can help to turn those frontal lobes back on in the brain. Functional communication training is another great way to deal with anxiety. If we can find a way to help the child communicate, then they can often tell us their fears and we can help to address them. And whether that means by helping them solve whatever problem they're having, or whether that means helping them to use a coping strategy. If they can tell us what is wrong, then we can often help to decrease their anxiety. So, for example, a boy with limited verbal abilities gets terrible stomach pains. And when he starts to have symptoms, he does self-injury behaviors, even before he starts to feel really bad pain. Once he feels those symptoms starting, he gets so anxious knowing that it's coming. So we taught him to use an alternative communication device to teach him to tell us that he's starting to get these symptoms of this terrible stomach ache, and then his parents can give him the medicine that he needs to prevent it from getting really bad. Sometimes, without addressing anxiety, no behavior intervention plan will be effective. Anxiety will always determine the behavior. That is when a behavior is related to anxiety. So let's say a boy asks questions over and over, looking for affirmation, specifically about his parents leaving, going to jail, not loving him, stuff like that. Behavior plans using differential reinforcement, extinction, those kinds of strategies were not effective. But when interventions to address anxiety were included, the behavior decreased. The behavior interventions did nothing to decrease the underlying anxiety. So the behavior didn't change. The stimulus, the thing that was leading to the behavior was still there. So there was no change in behavior. The power of the anxiety continued to outweigh any reinforcement that they were offering through the behavior plan. So the behavior continued, and it even escalated because now they were the parents had changed their behavior in accordance with this differential reinforcement plan, no longer responding in a way that gave him the reassurance he was looking for. So the behavior escalated as he continued to attempt to solicit that response. We'll talk more about how to get out of this cycle a little bit later, but just note that if anxiety is truly underlying a behavior, the only way to change that behavior is by addressing the anxiety. Now, one of the most challenging behaviors for parents to deal with are meltdowns or tantrums, and I want to make a distinction between meltdowns and tantrums. When anxiety is so high that we're unable to think about or in any way regulate our emotions, when that human part of the brain turns off and all of our information goes straight to our lizard brain, no explanation or reasoning is going to work. In addition, most of the coping skills that we teach kids go out the window. Deciding to use a coping strategy requires cognitive recall, and that is not online when we're in this state. We don't have any frontal lobe functioning, so we can't use those skills that we need the frontal lobe to do. A tantrum, on the other hand, is intentional. A tantrum is behavioral. A tantrum is a way to a tantrum is something that has been reinforced, and that's why it's happening again. That's why it's happening at all. Whereas the meltdown is total nervous system, out of control. I can't control this. In a meltdown, the child needs your help to emotionally calm down. Behavior interventions alone are not likely to succeed because the child is just out of control. It's the nervous system that is taking over, or that has completely shut down any inability to reason or to think through things. Now keep in mind that everyone expresses anxiety differently. So while one child might have a meltdown as we often think of them, crying, screaming, maybe hitting, another child's meltdown might look more like tuning everything out, just shut down from the world, not taking in any information. Whereas others might increase their stemming, some might not be able to speak, some might run away. These can all be signals of nervous system shutdown, depending on how your child expresses their anxiety. But if we deal with whatever this meltdown looks like, however it is that they express their anxiety, the way we deal with it is largely the same. We help them calm down the nervous system. Now, you might be familiar with social programs like the zones of regulation, which is the purpose of the zones of regulation, or the intent of it, is to teach emotional regulation. And I really like this program. It's great for helping kids to identify their emotions and learning how their emotions and their behaviors are related to their social success. This also includes tools to help kids when they need to increase or decrease their energy or emotions. So it's a curriculum that goes through exactly a lot of different strategies that kids can try and see what works for them. However, we need to remember that this program is very cognitive. It requires lots of thinking, lots of planning, lots of frontal lobe functioning. We're teaching our kids to think about their emotions, to think about their behaviors in response to their emotions. And while this is a really important skill to learn, it does not work when we're in fight or flight or that meltdown mode. We're not able to think when we're in that state. So all of this information, including the ability to identify the emotion, goes out the window. So while these strategies are great for helping a child keep themselves from reaching the breaking point or reaching that fight or flight mode, we need a different approach once the anxiety gets that high. So what do we do when we're that high, when the nervous system is that anxious? Well, we have to help the child calm down. Think of anxiety as a superhighway. When we're stuck in a loop of anxiety, anxious perseveration is more likely when positive examples or pathways don't exist or are harder to access. So if the brain is a series of roads, we have certain responses that we use as default. When we encounter some stimulus, we have the same response to it each time. The brain follows that same path from the identification of the stimulus to a response, the same response. This is a superhighway. It is a huge, easy to access, and well-traveled road. This is the I-35 if you're in Austin. Each time we use the superhighway, it becomes even easier to access, and likely that we'll choose it again in the future. If this road got me where I needed to go, then this is the road I'm going to take again next time. There might be other possible responses, and these would be the other roads, other routes in the brain, other ways to get where you're going, but they're less easy to access, and because we don't use them very often, they're not very well traveled. These are the side roads, and even the very small, little teeny tiny dirt roads that you might see. They're there, but we don't use them very much. So in the case of anxiety, the patient might have multiple options for responses to a stimulus, but the superhighway is the easiest one to get to and the one that's used the most often, and that's the anxious response. That's the response that we're going to use by default. So we need to make those side roads or those alternative responses to the stimulus easier to access. And we do this by using this different response. Each time we use the alternative response, we make that road a little bit bigger and a little easier to get to, thus making it easier to use this response by default. Eventually, this new route can become that superhighway, and the anxiety route can become one of the smaller and less used roads. To do this, we use different behavioral and counseling techniques. We've talked about prompting a response to a stimulus. This is often needed to access or create one of those smaller routes. So remember that these routes we don't use by default, so a prompt is needed to take that road instead of taking this anxiety response. So imagining the stimulus and the response that you want is also effective, especially when the help, excuse me, especially when you have the help of a therapist to process any barriers come up. You can imagine yourself encountering the stimulus and responding in the way that you want to be able to respond. Having this imaginal scenario over and over can actually create this new path in your brain, just as you would if you were actually experiencing it, especially when you have the help of a therapist. Often, any barriers that come up that prevent you from being able to see yourself being successful are related to anxiety, and then can be related to past experiences or things learned indirectly that have led to negative beliefs about ourselves. Now, when a child is really anxious, having a meltdown, in that fight or flight state, your nervous system is key in helping them calm down. If you can remain calm, if you can model anxiety reducing techniques, their nervous system is tied to the nervous systems around them. If they're unable to control their own nervous system, being around your calm nervous system, imitating you deep breathing, or you doing some progressive muscle relaxation, can help to bring them down to a state where they can then think about and use the techniques that they do have. Cognitive behavioral therapy and acceptance and commitment therapy have quite a bit of research to show that they are effective with the autism population. Both use strategies that teach the person to analyze their thoughts to assess whether they're accurate or not. Is this thought real? Is this a real threat? No, then I don't need to be scared. I don't need to react this way. But keep in mind that such strategies are useless when in a heightened emotional state. And it's been my experience that an emotional tolerance component should also be included, where we teach the child to tolerate unpleasant emotions and increase and access the different pathways in the brain to positive responses to stimuli. So little bits of unpleasant emotion at a time, gradually increasing that, while also teaching them to use the different responses and create those different brain pathways. And now it may be necessary to adapt the standard CBT and ACT interventions for children with autism. And ways to do that are things like making the techniques more concrete and engaging. Visualizing can often be a good way to make it more concrete for someone with autism. Maybe personify the anxiety and talk about it as something that's separate from the child, or drawing pictures of the thing that causes the anxiety and the thing that the technique we're using to stop it. We're almost out of time, so I'm going to go through these next couple of slides pretty quickly. Exercise and meditation are also empirically proven to decrease anxiety. I have a couple of sources here that I'm not going to go into detail about their findings, but suffice it to say that exercising and meditation both have research to back them up as effective treatments. And for some children, medication may be needed for the short term or the long term to help to manage anxiety. This is especially true when there are comorbid mood disorders or dangerous behavior problems. Talk to a general practitioner, psychiatrist, about whether medications might be right for your child, but know that when medications are used, we get best outcomes when they are combined with other interventions like behavioral therapy or counseling. So in summary, anxiety is a normal and necessary physiological response that is only a problem when there's too much of it. Individuals with autism do experience anxiety, but it might look very different than it does for those without autism. A correct differential diagnosis and ruling out other possible conditions is necessary. Those with autism may experience even higher levels of anxiety than the neurotypical person. CBT, ACT, and positive behavior support are effective treatments for anxiety in those with autism, and exercise and medication are also effective. And it takes a lot of practice to create different responses to an anxiety-inducing stimulus. The new response needs to become the default neural pathway for that to become the default behavioral response. Unfortunately, we don't have time for questions, but I do encourage you to send in any questions that you have so that we can create future webinars to address different aspects of anxiety more in depth. I have a few resources, some books, the Anxiety and Phobia Workbook by Byrne. The Childhood Anxiety Network is a great website with lots of information. Taking Back OCD by March and Benton, and My Anxious Mind, A Teen's Guide to Managing Anxiety and Panic by Tompkins and Martinez. Information in any of these resources may need to be adapted to individuals with ASD as we discussed, making them more concrete, more visual, and more engaging. Please visit us on YouTube. All of our webinars are posted on YouTube and can be accessed for your reference. Please also follow the Johnson Center on Facebook and Twitter, or sign up for email notifications to get information about upcoming webinars. Our 2017 schedule will be coming out soon and can include additional webinars on this topic. And if you have any questions or are interested in any of our services, please contact the Johnson Center at info@johnsoncenter.org or 512-732-8400. I thank you so much for listening in today. If you would like a certificate of attendance, look for a follow-up email that will be coming in the next 24 hours. It will have a link to a short quiz that once you complete, it will allow you to download a certificate of attendance. Thank you so much, and I hope that this has been helpful. Please send us any more questions that we can cover in the future. Thanks so much.